Hi, I'm Sarah Bowden.
Hey, Tyler Dolan.
Hi, Marissa Muley.
Okay, so I worked on my own today, as you guys know. I had 4 patients, I think, throughout the day. And so with my first one, it was kind of hard getting back into the swing of the clinic just because we've been in classes so much and working on specific stuff in MS.
Yeah, feel the same way.
Yeah, so with her, I was good about not over-analyzing too soon because she had a diagnosis. I knew we had to work on jumping and quad control because it was an ACL. And she was able to tell me a lot of what she did before. But what I was too focused on like her body mechanics and wasn't thinking ahead for the exercises because I didn't have any prep before she came in. It was just like she came in and it's like, okay, talk to her, then figure out what you're doing. So once I figured out an exercise, I kind of stuck on that exercise, analyzing how she was moving through it. So I need to work on like being prepared rather than thinking what the next exercise is when she's supposed to start it. With the next patient, I did a little better with that. But because there was some pain in the posterior knee that like we didn't really know what it was, I was over analyzing and not really letting the history take me and just working on function rather than worrying about diagnosis like we've been doing recently. And then with the last 2, it was good because they were already diagnosed as well, and I was able to go based off of previous treatments a lot and just either progress, regress based off of how they were for the last treatment.
That's good.
So I was able to get a little further into it. It's just always hard when it's a new patient and they're in the middle of the treatment.
Yeah.
Trying to figure out how to pick up, like, progress, regress, like, you're coming in the middle, so I find that a little difficult.
Yeah, I agree with you.
Yep, definitely same for me.
And then documentation. Were you okay with that?
In the beginning, it's always like the whole, okay, what is this section supposed to be for again?
Yep.
Yeah.
So I confirmed it with Dr. Pfister to begin with. I think he was the first one that I documented for. In the beginning, I was definitely overthinking it. I had to remember back to the patient because I had kind of moved on from the patient when I was documenting. But as I went, and I was just like writing more because I wrote 3 of them, I think. 2 full ones, actually. I did 2 full ones.
Nice.
So after the first one, I was able to kind of have like a flow and knew what went where. And especially with the plan for the next time, after writing one assessment that was really wordy for Dr. Drager, so actually there were 3, but after writing an assessment that was really wordy, she's like, yeah, you have everything there, but I would have probably wrote it in 2 sentences rather than 4 or 5. So when I went to Dr. Pfister's documentation, I wrote it in a lot less words and realized that not completely telling a story, but just like the little parts is enough.
Yeah, I know it's really challenging when like you're not like documenting every single day, or like if you use a new like documentation software, like it's certainly tough because you're not like sure what you're clicking on or like what does what.
That, and I noticed like a lot of the times when we're in there with them, they're documenting while the next patient's doing an exercise, like they're watching and documenting, so they can at least write down the overview, and that way they can go back and add to it if they need. But when I went back to doing my first patient of the day, was my last documentation, so I had to ask Dr. Pfister about specific details that I had forgotten because I'm not as...
It happens. Yeah. You get so involved with the next patient, the next exercise, and
it's hard to go back.
Notes come in handy.
Yes, they do.
But just like finding structure was difficult. But again, I think it just goes with, lack of experience. We haven't had a lot of time in the clinic yet, but I'm sure we'll attain that as we kind of get out into our rotations.
Towards the end, it got better.
Yeah. But I think that's impressive that you handled 4 patients on your own with obviously help from Dr. Drager and Dr. Pfister. So it's very impressive.
You did a great job today.
At first I was a little like, damn, I'm on my own today. But then like afterwards I'm like, okay, with the practical tomorrow, actually coming up with interventions, it helps for practice with that. So when I first got an ACL, I was like, perfect. It's reminding me of everything we need to do. But doing that like gave me more of the individual practice rather than like leaning on someone else. So I kind of enjoyed it once like the nerves of being by yourself were kind of gone.
It must have felt really good.
Because we had each other.
So,
even though I think it helps with the documentation in a way, like unless you guys like took turns doing different sections, because you're both thinking the same thing in different ways, but I think it actually slows you down with the documentation in a way.
So even though you weren't quite there to watch us do it, I think you kind of hit the nail on the head.
Yep.
Literally.
That we tended to kind of collaborate on things, but I think because it was kind of two minds trying to like merge into like one sentence or you know, try to say a single thing, it made things more difficult. But I think it does go back to just like, we kind of had to review, you know, what exactly did we say in assessment, or like what, you know, fits in subjective, but, you know, we have to take out because that actually goes in objective, you know, stuff like that. Small things, just maybe that were just a little bit more difficult because we haven't had a lot of repetition with it.
Right. So maybe a recommendation for next time for you guys, like have one person do the assessment on one patient and the other person write the assessment for the other.
Yeah.
That way you get the practice of writing it on your own, and the other person can be there and like assessing it for you once you're done, before you actually call over Dr. Drager and Dr. Pfister to like do the final assessment of it.
Yeah.
I think that's a good option. I think that's a good way to
It
do
should
that.
probably be faster because you can assess as they're going and just pick up on anything they missed at the end.
Which is good for both of us.
Yeah.
Agreed on that. That was good.
Yeah,
Thank you.
that was a little setback documenting.
Yeah.
But we took turns with coming up with exercises, which was great.
Seemed to flow really well between both of us. Just
which was good.
basically identify the impairments. In the beginning, I think, I mean, I was, and I don't know if you were, but maybe thinking a little bit too much about trying to find appropriate exercises. And really it's just like, look at the impairment and then like find an appropriate exercise that deals with that. It's like really more simple than we really make it out to be. Which is kind of like, I guess, the moral of today's
don't overthink.
Yeah, don't overthink. It's much more simple than you think.
Yes.
So. But you did good with all the joint mobilizations. We had 2 new ones, actually 4, but she broke it up into, you do those 2 motions, and then I did the other 2. I mean, your line of drive was really good.
Thank you. Same for you.
You held it. It was hard for me.
You still maintained it. You still maintained it.
It was good though, and it showed improvement in the shoulder.
Yeah,
so
it was really nice to kind of see that improvement like immediately after the intervention. To just kind of notice that change in mobility.
Yes.
And yeah, I was gonna say something. All right.
So I thought we were a good team. Definitely need to work on stuff. You know, all of us documenting.
Yes.
But I think that's just practice, like you mentioned, over and over again. But
How did you guys do with the eval? I know there were some things.
Yeah. So the eval I think went pretty well. It was a little bit more complex than I think what we were used to. Or like there are some things that Dr. Drager did that we haven't really been taught yet.
Yeah, we haven't
so just kind of regarding that. But it was
Right.
actually I think really beneficial to see how it was done. From her, and then kind of see how she screens based on the initial impairment that your patient comes in with.
Yeah, like we had a totally different plan going into it, and she's like, you don't need that.
Right.
Because she was functional, she was moving. So it's like if we go down the path of range of motion and then it leads us to somewhere else that has nothing to do with it, we just wasted our time.
Yeah,
Right.
exactly.
And we really just need to figure out the areas around it, and she figured it out.
And initially we weren't completely off with our choice of where we're going to assess first. Like we're deciding to look at the shoulder. The patient kind of came with a trap
Scapular
issue.
movement for sure.
Yeah,
which was good.
yeah,
she liked that.
Exactly.
Said that.
So we got that, but I think we delved a little bit too deep into the shoulder when it really wasn't. That wasn't the issue.
Too practical. I think we're so focused on like step
joint,
1, step 2. Yes, because once we knew it wasn't coming from the joint, move on. See if it's muscle, and then see if it's cervical, come from the spine.
And also I think a big realization on my end is that not everything, especially in the real world within the clinic, is going to be so structured as things are that we're taught in class, and how we do things in practical. It's so vastly different. Like when I was doing my history, I kind of started off exactly how I would have been practicing practical. Again, very structured to the point, but your patient may throw you something that was like kind of out of line, and something you didn't expect. So like that kind of threw me off. Also being the fact that it was my first real patient I've done an evaluation interview with.
You hit every point though, and you got what you needed.
Yeah, I got a decent amount, maybe forgot a few things, but I guess it's expected with still learning.
Oh yeah, of course.
Yeah, I need to remember that even with patients coming in. So how have you been since the last treatment, rather than jumping straight in?
Yeah,
definitely. Almost forgot to ask that earlier today too. We're just like, all right, we're gonna go on the bike, and how are you today?
Squeeze it in there.
I meant to say that. That was
so
part of the
just got
plan.
to get those subjective findings first and foremost every time. You know, that's important because that will tell you like how they've been doing at home and whatnot, how they're doing today, and that will kind of guide your treatment. And again, that's kind of goes into like how things can't always be structured the way you want and how you have to adapt on the fly.
Yeah, we gotta be flexible.
Yes, for sure.
But it was a good first day.
Yep.
Yes.
Looking forward to the next one.
Yes.
But,
Cool.
all right.
Good job, team.
Oh, I have to unlock it.